Hello, and thank you very much for asking me to speak. Many thanks to Satyen, my friend, for inviting me, along with my good colleague Robert Lee, to debate whether open or MIS, minimally invasive techniques, are best for adult deformity surgery. And I've got to take the view that open techniques are best. So let's get into it. And okay, so open surgery is best. MIS is a risk not worth taking. We're all familiar through our training. Most of us are probably orthopedic spinal surgeons. We're all familiar with principles of orthopedic fracture treatment, which is to provide stability, restore alignment, and respect the biology of the tissues to maximize function and gain solid healing. And the principles of deformity correction are very similar. We need to get stability, which is usually achieved through fusion and instrumentation, either pedicle screws for posterior surgery or anterior instrumentation. We need to restore the alignment. Both the sagittal and coronal balance should be maintained. Of course, sagittal balance is very poorly tolerated in adult deformity patients, whereas coronal balance is much better tolerated. And we need to respect the biology. We want to avoid things like infection. We want to optimize our patients, tell them to stop smoking, and we need to work out what's the best bone graft or bone graft substitute that we're going to use in order to achieve our fusion. And we want to maximize the patient's function, which in the spine perhaps means minimizing the number of levels we operate on and fuse. So what is minimally invasive surgery? Well, this is the first problem. Is minimally invasive surgery posterior surgery through stab incisions with percutaneous screws? Is it minimally invasive to do percutaneous screws but to fuse a longer segment than if one was to treat a problem through traditional open surgery using an anterior and posterior approach? Is minimally invasive surgery the same length of incision but using a muscle sparing approach such as the Wiltse approach to avoid the muscle stripping associated with traditional open techniques? Is it minimally invasive to use the anterior approaches which are common, such as the trans-psoas, often called X-LIF, or the O-LIF, anterior to psoas approaches? There's no agreed definition of what constitutes minimally invasive surgery, and this is half the problem. There's been a published algorithm for the management of adult deformity. This is from Praveen Mamanani's his publication, but it's from his group. And essentially, they classify them into three groups. A class 1, where they consider MIS surgery rarely requires a fusion or only a single level fusion. Class 2, with an interbody fusion of the apex or the entire curve. And then class 3, which they consider not suitable for deformities, are called class 3, not suitable for minimally invasive techniques, and recommend open surgery. This is an example that they give in their paper of a class 1 deformity suitable for minimally invasive treatment. And I'm struggling to see the deformity. This is the straightest spine I think I've seen this decade. This is one of their class 2 patients, and their pre and post-op views. And this is the class 3, which they consider open surgery for. So, I mean, I can't even see the deformity in the class 1 patients. Class 2 patients wouldn't get surgery in my practice, and for class 3, of course, we're recommending open techniques already. So I'm not saying let's do the biggest operation we can. That's not my point. We all want to minimize the collateral damage from surgeries, but we need to achieve the aims that we set out at the beginning of the talk. My impression is that MIS is often driven by the health insurance companies or the payers of the system, and it's seen as a driver to reduce length of stay, which is conflated as an indicator of quality, and I have a big problem with that. I don't think that this is actually something we should be striving officiously for. We want good outcomes. We don't want short outcomes. There's some recent evidence and a lot of minimally invasive papers that compare open versus minimally invasive techniques come up with a similar sort of conclusion. This is a paper from this year, from the International Spine Study Group, and when they compared open versus circumferential, that's what the C means, circumferential minimally invasive techniques, and they tried to match the curves and the pelvic parameters and the groups of the patients in total, and they concluded that, and this is key really, well selected patients had less blood loss, comparable results in the short to medium terms, but longer operative times in comparison with open surgery. One paper which raises a concern for me is this paper, again a recent paper, documenting the high radiation doses used during minimally invasive approaches. So they had a group of 52 patients who had their circumferential minimally invasive deformity corrections, on average a 5-level fusion with about 3 lateral cages, and quite a significant fluoroscopy radiation dose. So with quite a large range actually. So between 33 and 1,000 milligray of radiation, but the average emission dose exceeded the annual risk threshold by 36 times, which is a significant amount of radiation, not something that should be minimized, and a concern for the future, not just for the patient, not just for your patient, but for yourself as the operating surgeon and your staff. Okay, so let's take a couple of my cases. So first of all is a 70-year-old lady who was very fit, but had a long-standing deformity that was getting slowly worse, both in terms of her shape and the fact that she was getting more problems with pain and tired easily. She'd had a previous decompression for root symptoms of the L3 nerve root elsewhere, but this had given her no or very minimal benefit. This is the preoperative X-rays with a significant a significant right lumbar curve. Here you can see quite advanced degenerative changes and a hint of a slip at the L3-4, lateral listhesis at L3-4, which is commonly seen, and an overall loss of the lumbar lordosis, global sort of thoracolumbar kyphosis, very typical picture. CT scan suggested that the apex was fused or nearly fused in the concavity with significant osteophyte here at this level. So the decision making really that I sort of went through, decision-making process I went through was, should I do front and back surgery? Perhaps I could treat it all posterior with an osteotomy, either a pedicle subtraction osteotomy or multiple Smith-Peterson osteotomies. I perhaps wanted to go back and have another go at decompressing the L3 nerve root and get fusion. And was that fusion going to be circumferential or posterior only? And what about the instrumentation? Should she have a fusion of the whole spine, T2 to the pelvis, or would I be able to stop at the thoracolumbar junction? Perhaps I could stop at L5 rather than going to the sacrum or pelvis. This is the outcome. This is what I decided to do. I stopped at the T11. I didn't feel the need to instrument the whole of the thoracic spine, but I did do an asymmetric pedicle subtraction osteotomy here at the L3 level in order to restore the coronal balance, and I instrumented to the pelvis, but no anterior surgery. And she did well from that. I think she broke her rods at about 2 years. We redid the rods, and that was the only surgery. So she only needed revision of her posterior rods and no anterior surgery. Second case, 75-year-old lady with a degenerative spondylolisthesis as well as a lumbar curve. Not as severe a deformity on the coronal plane on the AP X-ray, but a L5S1 lytic spondylolisthesis. Initially, she was fixed by my predecessor, and he had a similar approach to me, but without the pedicle subtraction osteotomy and fixation with sacral alum screws rather than iliac bolts. But she eventually loosened at the bottom end, so you can see quite a lucency around the sacral screws and the alum screws here. And she eventually started to decompensate both sagittally and off to the left in the coronal plane. So again, I did a similar thing. I did an osteotomy, which I don't think you can do minimally invasively. You certainly can't do it safely. I extended the instrumentation to the pelvis and higher up into the thoracic spine. And the key to the outcome here is the restoration of the sagittal balance and the lumbar lordosis through the osteotomy. And again, this is not something that I can't do an osteotomy through a previously instrumented rigid spine using minimally invasive techniques. Next case is just to illustrate the fact that a short segment front and back surgery, in my view, probably, can be considered as minimally invasive, even though it's a traditional open technique. A 60-year-old lady with post-traumatic kyphosis. She was hit on the head by a canopy, an awning that came out from her garage, and she was sort of collapsed backwards, and she had a fracture of the upper lumbar spine, which was initially treated conservatively, but in the end wasn't going to settle, and she had severe symptoms of pain and mechanical instability. So she had a same-day front and back fusion with initial surgery was anterior, placement of an expandable corpectomy cage here filled with the bone from the fracture site with an anterior plate, and then same-day posterior surgery with screws. So traditional open technique, but because it doesn't require too many levels fused, is probably better for her than a technique. I've seen some people describe percutaneous screws over a long segment for a similar type of fracture fixation, which in my view is more invasive than a shorter segment front-back fusion. So of course there will be some cases more suited to others, to MIS than others, but the cases that I see that I would classify as proper deformity are those with need revisional instrumentation or have previously fused or naturally occurring rigid spines that need an osteotomy, or have severe deformities that require open anterior release or complex techniques like vertebral column resection, although I try to avoid this if possible, but I think it's a dangerous operation to have. So in summary, my plea is we must obtain stability with adequate instrumentation, restore the alignment, and aim for the return of function whilst respecting the spine and the biology. The traditional aims of every spine surgeon treating deformity that there has been. We must not sacrifice the outcome or those objectives for the sake of a new technique. Additionally, please, if you are considering doing minimally invasive surgery, please make sure that you feel it's worthwhile going through a learning curve in order to achieve it. Get a mentor, but if you have good results with open surgery, then stick with it, because I certainly will do that. And I'm going to hand over to Robert Lee now, or perhaps he's gone before me. I don't know. I had no idea what he's going to say. So perhaps there may be some questions we can answer those live. Thank you very much.